to our first Taste of Graduate School event. I have the pleasure of introducing Dr. Fairley, who is a 2-year supporter of doing this for us. So thank you, Dr. Fairley. In front of you, you should have his biography, but I'm going to go ahead and read it out loud. So Jeff holds a bachelor's degree in exercise science and a doctorate degree in physical therapy both from University of Southern California. Jeff earned his board certification as a specialist in orthopedic physical therapy in 2002 while completing the Kaiser Orthopedic Physical Therapy residency program. He continued additional postgraduate education in manual physical therapy at the Kaiser Fellowship Program in Manual Therapy in 2003. As a practicing physical therapist, Jeff has worked in a variety of settings, including acute cardiac rehab, but has concentrated on outpatient orthopedic and ambulatory neurological physical therapy. Comprehensive spinal care, including manual joint mobilization, motor control, re-education, and reformer-based Pilates exercise training is the foundation of Jeff's specialty. Pre- and post-operative rehabilitation of peripheral joints utilizing a validated and reproducible clinical reasoning approach are hallmarks of Jeff's care.
And read that fast.
Jeff also runs the pelvic floor rehab program centered around a computer-based biofeedback system that assists in the restoration of pelvic muscle function and urinary continence. Jeff is a self-described foot nerd who enjoys treating the often avoided and complicated area. From functional taping to custom orthotics, happy feet are seen leaving the body center after seeing Jeff. From head to toe and everywhere in between, Jeff has your patients covered. And in addition to his awesome biography with him being a great and awesome physical therapist, read up on a testimonial, and I'll actually give you a copy, Dr. Fairley, of a student who was really impacted by you. So read what the student has to say. A couple housekeeping programmatic announcements. Make sure you are reading my emails. I recently sent 1 or 2. I sent 2 this past week, so read them. If you need to set up one-on-ones with them, I'm doing those next week. But if that doesn't fit in your schedule, I could always make time for you. And that's just a way for me to check in and get to know where you are in life, in school, along with the program. So I am gonna publicize an important event that we want our cohort to go to, and that's the focus group, which is going to be October 20th. Actually, I may be on the agenda. It's October 20th from 12 to 1:30. So Friday, October 20th from 12 to 1:30 with our survey folks who are going to serve pizza. So come and eat lunch. So that's our busy programmatic day. But if you're attending the one before, the grad programs and missions talk, you could just go to the focus group after that and eat pizza and then go to the one after. But basically, it's a way for you to put your input and then to get data on it, data on how things are going, how you are with the program, and information they might need from our cohort.
And the RSVP is going to be on the newsletter, which is going to go out on Monday. So just look at the newsletter, RSVP for whatever you can go to.
Yes, thank you. And then as a quick icebreaker, let's go around and say our names and then also answer what you do in terms of like a physical exercise. So I'll start. Yeah, you like that one, Dr. Fairley? I came up with that one on the fly. I'm pretty sure I had a different one. But anyway, so I'm Anna Kapinpin. I'm your program coordinator. And what I love to do for exercise right now is yoga, which has been amazing. And a selfish plug, please come to my self-care workshop. Mine's like the last one before your finals in December. We're going to do a little yoga, a little bit of everything else. Okay, so we'll start here.
Hi, my name is Johnny. For an exercise I like to do, I like running, so anything cardio, basically.
Johnny, right?
Yes.
Thank you.
Hi, I'm Lisa.
I really like swimming, and I also do some weights too.
Yes.
I'm Valerie. I don't really do a whole lot of physical activity, but I do walk a lot.
Good.
Yeah, that's it.
That's physical activity. Come on, yeah.
Hi, I'm Candace, and I also like to do yoga.
Good.
Hello, my name is Marilyn. In my spare time, I like to play volleyball. My name is Elizabeth, and I like to hike. And I just want to apologize now. I have to work at 1, so I have to leave a little early.
Okay. Life happens.
Hi, my name is Cynthia, and I like to go running.
Really? Okay, another runner.
Yeah.
Hi, my name's Kim. I usually play tennis or I would go to the gym.
Hello, my name is Jamlet, but I also go by Jam, and I also like to play tennis.
Hi, I'm Diana. I like to do target workouts like abs and then arms.
Ah, okay.
Yeah.
They were shooting stuff there for a second.
No. Hi, my name is Erica, and I also like running. But I like running outside. I don't like doing treadmill. I like doing outside.
I'm Jocelyn. I like playing soccer. I like chasing after a ball, not just running.
Hello, my name is Saira, and I walk to school, so that's what I do today.
There's your exercise. Walking here. All right. Okay, well, thank you for that introduction, Anna. So I am very happy to be here. I had a chance to do this last year. I had some pretty good feedback from the group, and so hopefully this can be like it is in class when I teach. So when we teach, I try to have a good time because we're trying to learn it, and let's not make life irritating. Let's make life fun, and let's try to learn something. So this concept today, the taste of grad school, what I really try to do is try to make it as close to what I have my students do in the classes that I teach. So I teach over at Western University. I teach in the physical therapy department. So I teach orthopedics, and I teach kinesiology. So kinesiology, kind of a base science, right? We're in the kinesiology building, right? So we've got a book, and it's like, there are all the rules and stuff like that. And then, so that's the class I teach in the spring. And in the fall, which is what we're doing right now, is the orthopedic course, which is a course in how do you manage problems that are orthopedic related in physical therapy. What if someone sprains their ankle? Well, what do you do? What if someone has low back pain? Well, how do you figure it out? What do you do? What if someone had surgery? And what do you can and can't do because they just had surgery, right? All that kind of stuff is what we deal with. So you might imagine there's not really a book for that. Right? I mean, the book on how to take care of somebody if they have an orthopedic problem, right? Well, there's like 10 books, and none of them are the same. And so it's like, well, what do you teach? So part of what we do is that we actually use what we call the scientific literature, as you guys are familiar with, to try and help support what we're doing. Because a lot of different books and authors are going to have different ideas, right? And we're going to look see are the commonalities, and then what does the literature inform us on as well. So one of the things that our students do is that we have an orthopedic reader. They basically have 4 articles or so a week, and every week they get a quiz. There's about 5 questions per article, so about 20 questions on the quiz. And every week there's a new packet. So this week we're doing the hip. And so there's 4 articles on the hip. One about labral tears, another one about psoas stretching, another one about exercise activity, another one about post-operative care for total hip replacements. Now, there are lots of different articles on hips, but those are kind of a few that I selected for them to kind of read through, and then I quiz them on. Sort of like what we did here, where we had an article, which I think you guys were given, and we'll read through the abstract to kind of make sure everybody's somewhat on the same page. But that article is what kind of this presentation is about. So kind of extrapolating from that article how we might apply that in real life. So the hope is that as you guys are going through your undergraduate work, you will be able to kind of master what we kind of talk about as far as that foundational knowledge-based learning, right? Can you memorize these facts? Can you identify this data point, right? But then hopefully you actually can start to take the next couple steps, which is to actually start to take that information and compare and contrast it with other information, or take that information and reapply it to a new situation. So, if we've learned that exercise is helpful in a certain population, well, is there any transferability into a different population? Or if one type of exercise gives us a certain benefit or effect, Will we see a similar effect or a different effect if we change the exercise mode? And what effects will change? And can we see a comparison and contrasting of that? So those are some of the things that we hope to be able to get to as we move through the graduate school level. How many people here are thinking about going into a health profession? Cool. All right, well, how many here are thinking about medical school? Oh, not as popular today. Okay, how about physician assistant? Very cool, got a couple. All right, how about physical therapy? Oh, got a few. How about occupational therapy? A couple more. Speech therapy? Ooh, a couple of speech therapists, very nice. Let's see, did I miss any of the therapists? How about more of the public health route? Yeah, very good, okay, public health. Health education. Wellness prevention, maybe it's kind of part of public health, depends on how you define it. Okay, cool. So hopefully there's a little bit of something in here for everyone in the sense of there's some specific things that you might be thinking about in a clinical medical setting. How do I deal with the patient in front of me, right? And then maybe there's some broader concepts that might talk about more broadly public health. And then hopefully people functioning at a higher level is effective, whether you're talking about physical therapy or speech therapy or occupational therapy. All right, so let's just, do you guys have access to the article, or did you guys have it earlier before? You have it here? Great, perfect. Let's just go through the abstract. So is somebody willing to read the abstract for me? Or at least we'll split it into two different people here. So who'd like to take the first couple lines, and I'll stop you and move it on to a different person? Well, you're closest, so here you go. So regular exercise, start right there.
Regular exercise provides a myriad of health benefits in older adults, including improvements in blood pressure, diabetes, lipid profile, osteoarthritis, osteoporosis, and neurocognitive function.
Oh, very good. We'll just go sentence by sentence. We want you to pick it up from where he left off. Regular physical activity.
Regular physical activity is also associated by decreased mortality and age-related morbidity in older adults.
Very good. Go ahead, keep going. Despite this.
Yeah, thank you.
So despite this third sentence.
Despite this, up to 75% of older Americans are insufficiently active to achieve these health benefits.
Keep going. Few
contraindications to exercise exist, and almost all older persons can benefit from additional physical activity.
The exercise prescription consists of 3 components: aerobic exercise, strength training, and balance and flexibility. Physicians play a key role in motivating older patients and advising them regarding their physical limitations and or
comorbidities.
Motivating patients to begin exercise is best achieved by focusing on individual patient goals, concerns, and barriers to exercise.
Strategies include the stages of change model, individualized behavioral therapy, and an active lifestyle.
To increase long-term compliance, exercise prescriptions should be straightforward, fun, and geared towards patients' individual health needs, beliefs, and goals.
All right, very good. So this all came from the American Family Physician Journal. Okay, so that's where this article came from. We're going to expand on that a little bit more, so it's not just focus on the physician model, but that's where this came from. Okay, so here we go. Let's see if it will work for me. Yes, so promoting and prescribing exercise for the elderly. Is the screen okay? Is there too much light on it? You guys good? All right. So it's never too late for patients to benefit from physical activity. So you just read that there's a lot of benefits associated with increased exercise activity. These include things like improvements in blood pressure. All right, so we're all familiar with blood pressure, right? Resting systolic, diastolic blood pressure, the amount of pressure that the vascular system is under, that the heart is pumping blood through, right? And we have a basic understanding that the increase in blood pressure over time puts an unnecessary stress on the vasculature, which may result in vasculature failure, which oftentimes would present as what type of problem? So failure of the vascular system results in what type of problem? What happens to somebody? Heart attack, right? So if the coronary arteries fail, it's a heart attack. What else could happen? I heard of a stroke, right? So vessels in the brain, right? If they fail, either through rupture or ischemic stroke, or they get blocked, right? That would be a stroke, right? The lack of oxygen going to the brain, right? Peripheral vascular disease, right? So if you have an artery that's not getting blood into the area, then you can have death or destruction of the cells because you're not getting oxygenated blood, right? So those are all end results of prolonged hypertension, right? Lipid profile, osteoarthritis, osteoporosis, neurocognitive function. Well, lipid profile, right? The amount of fat that's in the blood, right? That leads to the plaques that line the inside of the vessels. What about osteoarthritis? Alrighty, well, I won't ask how old you are, even though you guys are probably young enough, it's not really rude. I am over 25. So usually we think of skeletal maturity somewhere around age 25, right? So I can make the argument that everyone over age 25 has some amount of arthritis that is progressively worsening. That is to say that their peak amount of cartilage, the peak amount of physiology of the musculoskeletal system is probably met around age 25. And every day they're walking up and down the stairs and running on the bike, doing their thing, right? The production of cartilage doesn't quite keep up with the reduction that happens from wearing out. And thus over time, things slowly start to wear out and wear out and wear out, right? Grandma and grandpa certainly have arthritis, right? And mom and dad have a little bit of arthritis, right? And your older aunt has a little more arthritis than you do, but you don't have that much, right? As people get older, arthritis, right? So exercise can help to slow that down. But what about osteoporosis? You guys familiar with osteoporosis? Right? So we're talking about the density of the bone, right? The bone density. Well, bone density can reduce over time, right? And one of the counteracting measures we think about is exercise. Well, why does that happen? Oh man, we're not asking a lot of questions. That's okay. Who here is familiar with Wolff's Law? Wolff's Law. Sounds familiar, right? Ah, man. Okay, who's got Google? Google, Wolff's Law. Anna's looking at me. I'm on slide number 1. We're still talking. Read it out. You got it. Go. Yeah, no, I'm talking to you. I'm sorry for that.
Oh, sorry.
Yeah.
Wolff's Law states that bone in a healthy person or animal will adapt to the loads under which it is placed. If loading on a particular bone increases, the bone will remodel itself over time to become stronger to resist that sort of load.
All right, you guys heard that. What does that mean? Can someone restate that? Can someone say that in their own words in a way that makes sense to them? That was very scientific. Well done. But what does that mean? Go for it.
Does it mean that the more you use a certain bone, the more, kind of like strength training, if you exercise a certain part of your body, that part becomes stronger. So in that sense, but with bone.
Very good. Can someone else add to that? Yes.
Is it like the amount of stress that you place on the bone?
Keep going.
It straightens your bone in that matter, like the amount of stress that you place on it.
Very good, but there's a step in between. You place the stress on the bone, and then what does the bone do? Reread that Google quote one more time. Oh, too late.
It will remodel itself.
It will. Okay, so it will build.
Right. So there's a physiology that's happening with the bone, right? You put a load on the bone goes, oh, that's a big load, right? The body, right? The body says, well, we need to make that bone stronger, larger, more dense to handle that load because we don't want the bone to be damaged, right? So then the body in its natural physiology says, okay, we're going to lay down more bone to meet the demand that I just put on it, right? Well, if I do it on a regular basis, the body is optimizing that bone production, right? So the little take-home message is that you young ladies especially, but gentlemen, oh man, we got to stick together, right? Well played. I understand how you work. All right. So you guys are aware of the concerns that we have with females associated with osteoporosis, right? And part of that has to do with there is a neurohormonal regulatory element that's part of this system, right? So it's not just purely mechanical. The body regulates itself in part through neurohormonal control, right? And so we do know that because of that, there can be a drop-off in bone density in the menopausal years, right? A precipitous drop-off, right? Otherwise, you guys are pretty similar to us dudes, right? We all kind of have the same, but because of this neurohormonal change with menopause, there can be a drop-off in bone density, right? So we usually encourage you guys, hey, now while the growing is good, right? Do that weight-bearing exercise, build that muscle strength, do the strength training so that you stimulate your bones to be bigger and stronger now while you can. Because unfortunately, because you are given the gift of womanhood, you are going to have maybe this little drop-off here at the menopausal ages that none of us can stop. Fair? All right, so, oh man, we're on the first three dots. I better speed up, huh? Neurocognitive function, how could exercise possibly affect your brain? Doesn't make any sense, right? Exercise is just making my muscles work.
More blood flow to the brain.
Blood flow to the brain.
Better access to the resources.
Okay, we'll talk about that. I'm going to pose a counter question to you. What do you think would happen if you had less blood flow to your brain?
Then your brain wouldn't function as quickly or as well because it's like putting gasoline in a car, like the less.
Yeah. So the brain is kind of one of those areas that doesn't change very much. Homeostasis is maintained, right? What's the normal body temperature? 98.6, right? Yeah? No? What did you guys learn it as? 98.6, yeah? Okay, good. So all of you guys right now are probably right around that 98.6 number, right? Now we can turn the heater up real high and we'll all be sweating in our internal body temperature, 98.6, right? We can pump that air conditioner up like I would have it done, right? Bring a sweater. That's how my clinic is. Bring a sweater. It's gonna be cold. You gotta stay awake. I'm not gonna be hot. Bring a sweater. Or don't bring a sweater and be cold, but we're not warming the place up. Your internal temperature is still 98.6, right? Your body works very, very hard to maintain homeostasis, and blood supply to the brain, quite frankly, is the only reason every other organ exists. The only reason you have a liver is to filter the blood so the brain doesn't get toxic blood. The only reason you have a GI tract is to extract nutrients so that then your brain can tell your body where it wants to go. And there's enough glucose for your brain to function. Fair? So the brain stays pretty stable, right? So it's not really a blood supply thing. But how many of you have ever tried to learn a new dance, right? So my son's up here and he's like dabbing, right? I'm like, well, okay, that's kind of cool. I think that's like a year old or two. But right, he's learning this new dance, right? How many of you guys have ever tried to learn a dance, right? My wife and I, we did swing for a while, right? A little salsa, right? You guys right? A little dance, right? So your brain has to figure out how to do something. It's not your muscles, it's your brain that figures it out, right? So when you're exercising, it's sort of like a crossword puzzle for the muscle system. Think about that for a second. All right. Oh boy. Decreased mortality and age-related morbidity in older adults. Okay. This all comes from the article that we just read. I better speed up. I wonder what's next on this slide. A blank slide. That's always good. No. Okay. We're going to exercise for the elderly. That seems like the last slide. Oh, I'm going backwards. No wonder. I'm sorry. There we go. And it's gone. And now here comes a new one. All right. Regular exercise has been shown to reduce the rate of deaths, to reduce mortality and age-related morbidity in older adults. All right. So mortality. What is mortality? The proportion of people dying during a given time interval. Okay? How many people died in the last 15 years because of smoking? So the mortality rate associated with smoking over the last decade was X. That's what that term means. Well, what about morbidity? What is the age-related morbidity? The incidence rate or the prevalence rate of a disease, right? This disease we see in 3 to 5% of the population, or 25 to 40% of people in Western civilization or Western societies will have complaints of low back pain. Over the course of someone's life, nearly 80% of people will have complaints of headaches. The rate in which something happens amongst a population, and prevalence rate. Now, what's the relative risk? The ratio of the probability of an event happening. What's the likelihood that somebody would die from an ischemic stroke? What's the likelihood that someone would be born with 6 toes? Actually, I had a patient who came in with 6 toes, and here's the best part. I was treating her foot, right, foot nerd, and I didn't even notice it at first. She goes, "Did you notice anything about my feet?" I went, "Yes." There's a little extra guy there. All right. Okay, so regular exercise has been shown to decrease mortality and age-related morbidity in older adults. Mortality, proportion of people dying during a given interval. It reduces the number of people who die. The fountain of youth. Age-related morbidity, the incidence rates, or the prevalence of disease. Well, if it reduces the number of people that die, it also reduces the age-related cause of death, right? How many people, because they hit age 70, are going to die? Well, if you exercise, the likelihood of dying at age 70 goes down. There's fewer people die at age 70. What is the relative risk? Well, the ratio of the probability of this event happening. People are at a lower risk if they exercise. Pretty cool stuff. All right, well, the old. Old is a typo? I thought so. No, a typo. By the year 2030. All right, let's do the math here. It's 2017. So we're talking like 13 years from now, right? All right, so now everybody close your eyes for just a second. And picture yourself 13 years from now. How old will you be? You envision a family. Mr. or Mrs. Right. A career. How old will your parents be in 13 years? Excuse me. How old would your grandparents be if they're with us? God willing. Well, you can open your eyes. 22% of the U.S. population will be older than 65 years. So how many of your parents will be over 65 in 13 years? Yeah, right? And they're going to not be alone. There's going to be 70 million people who are going to be that old. Well, wait a second. The fastest growing segment of the elderly is a population over 85. Now, how many of your grandparents would be over 85 in 13 years from now? Yeah. Right? So this is what's known as kind of the old population. So if you notice, we used to think, well, 65 kind of retirement age, right? But if you see a lot of 65-year-olds, right, you're still like playing tennis, playing golf, a lot of them are still working, right? Some of them are even still taking care of their parents who are 85 or older. Okay, so activity levels generally decline with advancing age. Well, unfortunately, that's been true in my life. Freshman 15, it just kept on working, right? All right, you guys are familiar with the freshman 15, all right? No, not here. It's exercise school, man. Known for kinesiology, right? All right, so if we have activity rates that are declining, and they're declining with age, and we have an increasing number of people who are older and living longer, you're going to have a dramatic increase in old, sedentary Americans. Dun, dun, dun. So what are some of the benefits that we see in exercise with older adults? Cardiovascular improvements. Now, those of you guys who are exercise science, exercise physiology, kinesiology majors, this stuff here all sounds very, very normal to you, right? Whoa, the VO2 max. Oh, I know what VO2 max is. I'm all over that, right? You guys remember this? Now, I went to USC, and exercise physiology, kinesiology was a vaunted degree at our school. So we got the basement. We didn't get the new building. We got the basement of the old gym. Our lab was in the old shower room, right? And we had a VO2 max station just like this. And so the treadmill was set up, right? And so have anyone ever done a VO2 max test? Okay, so VO2 max is essentially measuring how much oxygen you're able to consume, right? So humans, our fuel is oxygen, right? If you go running, what happens? You start breathing more, right? Because you're taking in oxygen, your lungs, red blood cells, and hemoglobin is extracting the oxygen molecule out of the air, right? You're binding that oxygen molecule. It's getting to the muscle. The muscle is using that oxygen molecule to fuel the Krebs cycle to allow you to have this exercise event, right? In a nutshell, right? So physiology majors, exercise phys majors, we're all on the same page, right? VO2 max. If we measured how much oxygen you were consuming, we can know how fast your engine can run, how much your engine can do, right? And that's what this system is here. So there's a breathalyzer D here, so we can measure the amount of air that's coming in, and we can calculate then with the partial pressure of oxygen, how much oxygen is present. And then knowing that, we can then say, okay, now we can measure how much oxygen is being consumed by this individual. And obviously, if I'm walking at a slow, steady pace, I don't need a lot of oxygen, right? So we start the treadmill at a slow, steady pace. And then after we go for a little bit, we start to increase the speed. But now when we increase the speed, we increase the grade. So they're going more and more up a hill, more and more up a hill, right? So imagine sprinting after your soccer ball straight up the hill. Now, we put athletes on there. How many people here were an athlete in high school? Okay, pretty good, pretty good. How many people know one of those crazy athletes, like they cannot be stopped? The Kobe Bryant athlete, I'm gonna outwork everybody. Anybody know one of those type of guys, gals, right? So you put one of them on one of these treadmills, right? They're gonna set the record. They're just gonna run it. So they would run, and they would run, and they would run, and they literally would pass out on the treadmill. Any of you guys ever run on a treadmill? What happens when you stop moving your legs on a treadmill? Bye-bye, right? Boom, boom. There was like a big old giant hole in the wall from people who got kicked off the treadmill into the wall. So we were smart in our department. We didn't fix the wall. We turned that treadmill around so that it pointed, so the back of it was pointing out the door. And then we just opened the door up. But then when the next person fell down, they got tossed into the hallway, and everything was good. There was no hole in the wall anymore. So that's a VO2 max test. So that is your maximal oxygen capacity. Cardiac output is your stroke volume versus how much force of a contraction you can create, the rate, pressure product. These are all things that improve the function of your heart, which ultimately reduces your risk of coronary artery disease. Remember, we talked about when the vessel fails, what happens? Well, that's artery disease. And coronary artery disease leads to symptoms of hospitalization from heart attacks, from strokes, from peripheral vascular complications. Diabetes. Diabetes. You guys familiar with diabetes? Yeah? Where are my public health people at? All right. What do we know about diabetes? You remember anything about it?
Like in general?
Yeah.
Well, it's pretty much like your body becoming resistant to insulin.
Close. Where's my Google girl? I guess I should give her a better nickname than that. Let's look up diabetes. And one of my public health people, why don't we look up costs associated with diabetes in the United States, or healthcare costs associated with diabetes in the United States. So first off, let's define what diabetes is.
For type 1 diabetes, your body does not make insulin. With type 2 diabetes, the more common type, your body does not make or use insulin well. Without enough insulin, the glucose stays in your blood.
Okay, and why don't have someone else look up the causes of type 2 diabetes? Go ahead.
245 billion represents the economic cost of diagnosed diabetes.
Say it one more time.
245 billion.
245 billion dollars. Divide that by 300 million. 245 billion divided by 300 million. Now, there's about 330 million people in the country, about 290 million adults. So I'm kind of using an estimate of about 300 million people. Do we have a cause for type 2 diabetes?
Low exercise or sedentary being
sedentary lifestyle. What else?
Genetics.
Genetics. Good. What else?
Weight, fat distribution, family history, age, race, and if you have pre-diabetes, you're more inclined to have diabetes.
Is there a diet element there? Yeah. Yeah, diet. Well, let's say, what about diet?
It was just saying lifestyle factors, so diet is also.
Yeah, lifestyle factors, right? So choices in lifestyle and choices in activity, right, result in this chronic elevated sugar that then requires high levels of insulin to manage that ultimately burns out your capacity to make more insulin to manage the blood sugars that are elevated. And then the blood sugar, like anything else that's out of this homeostasis balance, can act as a toxic type of situation. And that toxicity can damage multiple organs. And those end organs, therefore, need support. Things like dialysis. Anybody know somebody who's on dialysis? All right, so dialysis where the blood is being filtered automatically through a machine instead of your kidneys being capable of filtering the blood, right? There's numerous other types of vascular problems associated with diabetes, retinal problems, peripheral skin problems, numerous problems associated with diabetes. Diabetes, as you heard, is amazingly expensive to take care of. Not 100% preventable, but largely preventable, controllable, reducible through lifestyle modification, changes in what people do and why people do them. So keep walking to school. All right. So factors that affect heart rate. So that's the cardiac output, right? So I mentioned that one up here. Or cardiac output is heart rate times stroke volume. That's how we get the cardiac output. And then we've got, wait for it. Ooh, fatty deposits. What's that? Coronary artery disease, right? So a patient was asking me, well, how does a stroke come about? Well, her husband's a plumber. I go, well, you think about your husband working on the pipe, right? And the inside of the pipe is nice and smooth, right? So the fluids can move through the pipe without a problem. But imagine that pipe's been there for 15 or 20 years and it was one of these steel pipes, and so it's starting to rust away on the inside. So instead of a nice smooth surface, it's a very ragged surface, rough surface, right? Well, that fluid keeps flowing through that pipe, and any kind of debris in the fluid will more likely get caught on that jagged pipe, on that rough inside pipe. And when one piece of debris gets caught, the next piece of debris gets caught to that, and the next piece of debris gets caught to that. Next thing you know, you've got these deposits, this lining that has started to narrow the size of that pipe. And now all of a sudden there's less blood flow that can get through and less blood flow that can get through. Anna, how long are we supposed to go? I want to make sure I don't go over.
Oh, like 12:50.
Okay, no problems. And we'll have a little time to do some of the stuff afterwards. Okay, so that's atherosclerosis, or before coronary artery disease. And so then here's some of the effects of diabetes across the body. right? So we get effects in the brain, we get weight loss, breath with alcohol, nausea, vomiting. This is what this elevated symptoms of diabetes and disease is for. We don't want that. Bye-bye. Okay, well, we talked about osteoporosis, right? Well, what does osteoporosis look like? Bone density loss in postmenopausal women. So here we go. We've got males, we've got females, right? And here we are, we're somewhere around 25. This graph says maybe 30. We'll take it. I feel better about myself. 30 is a good year. So we have male and female kind of peak bone mass, right? And then over time, right, with aging, there's a slow decline. But then look, what happens right here? Look at that rate of decrease. Accelerates for women, right? And then the slope looks very similar to a male. So the big difference is, yes, they don't peak quite as high, right? And that kind of makes sense. Males tend to have a larger skeletal frame and skeletal mass than females, right? So we're measuring total bone density or total bone mass. We're going to get more in males than females, right? Just like you have more in Shaquille O'Neal than you'll have in me, right? But what we see, though, is this big drop-off that happens right here. And what does that correspond to? Well, that's typically the menopausal years where you have a change in the neurohormonal status, and that results in this more rapid loss of bone. And so this sets a woman up, especially if we're talking about the old, to have a much lower amount of bone density. Now, why would that be a problem? Yes?
It could lead to more fractures or just injuries to the bone itself if the bone is weak.
Yes, the bone's weaker, so it leads to more fractures. And the fractures are usually as a result of what? Falls, right? So you like to play soccer, some of the other guys like to play sports, right? I'm willing to bet that sometime in the last year you fell to the ground, either intentionally to slide into second base or to steal the ball from your opposing soccer player, or you're like me and you tripped over something, didn't realize it, down you went, right? Or you've got like a 6-year-old who thinks tackle football is cool, and so he takes you out when you don't know it, right? But anyway, you get tackled, right? Or you fall, right? And most of you did not fracture a hip when you fell. Right? When you lost your balance and landed on your arm, you didn't break your wrist. When you went to lift something heavy in the backyard and you were cleaning something out of the garage, you didn't fracture vertebrae when you went to do that powerful lift because you're not osteoporotic. But if you were osteoporotic, those types of events could result in injuries or traumas, even though they're kind of normal events that humans go through, right? Humans occasionally lose their balance and fall, right? That's the result of having your center of mass above your base of support and having gravity around, right? Sometimes you don't keep your center of mass over your base of support, and your center of mass finds gravity, and it works uniformly. Now, quality neuropsychological health. What, pray tell, is that? Oh, I'm sorry. This is normal hip. I skipped right over it. Osteoarthritis, right? So what does osteoarthritis look like? I talked about arthritis, right? The breakdown of the joint structure. So here's a hip joint. And that looks like what we call a normal hip joint, right? The femur and the coxofemoral joint, or the acetabulum, right? So it's an outcropping of the pelvis. And that ball and socket is sitting in there. Right? And the femur, we'll go through some kinesis real quick, can move in all 3 cardinal planes. Do you guys remember the cardinal planes? Sagittal? Is that sagittal? Something begins with an S. Sagittal plane, right? Everyone go like this. Yeah, and go up and down. That's flexion and extension, sagittal plane. Okay. What about, give me another plane. Frontal plane. What would be a movement in the frontal plane? Yeah, abduction. Well, she even knows the names. I love that, right? So that would be like jumping jacks, right? Abduction and abduction. Okay, give me the third plane of the cardinal plane. Transverse plane. What would be a movement in the transverse plane? Yeah, like rotation, right? Rotation. transverse plane movement, right? The hip can move in all three ways, right? You do it right here at your table. Bring your knee up. Don't bang the table, though. There's flexion, right? Bring it back down. That's extension. That's sagittal plane, right? You kind of pull your knees in and out, right? That's ab and adduction, right? And if you kind of roll your leg in and roll your knee out, that's internal and external rotation, right? So that ball and socket can move in all three planes. Cool stuff. I like that. We'll crease in there when we can. What do we see here? So these are some of the signs of arthritis. Why is there decreased joint space? So take a vacuum and suck it out. Well, what made the joint space to begin with? How many, I don't want to offend too many people. How many people here are meat eaters? Man, not that many. Okay. How many people here have ever had like chicken on the bone or the big turkey leg when you go to like one of the amusement parks, right? And if you take off the muscle meat, right, you're left with the bone. And on the top of the bone, there's like that spongy, white, crunchy stuff, right? It's cartilage. And the end of the long bone is cartilage. If your cartilage levels diminish, the bone part gets closer and closer together. If the cartilage on the edge starts to get banged up, right, starts to get nicked, the surface is no longer smooth. Now, you guys, you actually still have them. But if you look at the ceiling tiles up there and compare that to the wall that's here, the ceiling up here. The ceiling up here is kind of smooth and flush, right? And then the ceiling tiles over here have these little potholes, these little acoustic tiles, right? So if your cartilage is starting to get kind of potholy, right, then there's going to be more friction as the bones go against each other. That potentially is a source of pain. But as that cartilage breaks down further and further, you start to get the worn cartilage that you see there. Okay? So that's quote unquote natural. So that is osteoarthritis. All right, well, neurophysiological health. Oh, yeah. How many guys got a sleep number bed? I got one. They made a big deal for physical therapists, and they said, oh, you can get a sleep number bed for 40% off. I said, sign me up. Haven't seen one of that. Actually, I don't care. My wife, she's the one who likes it, right? So she's like, yeah, you know, my back's sore, make it a little firmer. My hips sore, make it a little softer. Whatever floats your boat, baby. So there you go. So there's that. So sleep, better sleep with a little bit of exercise. What else? I guess that's it. Oh no. Which ball you want to be? Yeah, me too. Right? It improves happiness, decreases rates of depression. Exercise combats depression. Right. I think I heard an article yesterday talking about the really high rates of teenage anxiety and depression. They're really high. And this is a simple, not simple, this is a way to combat some of that. Right? All of you guys are under a certain level of stress. All of you guys got to manage various types of emotions. There's lots of things that are changing in your world right now, right? From you getting finally independence and be able to do what you want to do and then having to pay student loans. Oh, wait. Relational stresses, your parents are getting older, those changes are happening. There's lots of things that are going on that can impact your mood state, right? This is a great way to kind of help manage some of that. All right, well, benefits of exercise in older adults. We talked about cardiovascular, we talked about neurological, neurophysiological health, and we got cancer reduction risk, all kinds of other improvements. So modest increases in life expectancy were possible even in those patients who not begin regular exercise until age 75. A throwaway line. What? What did I say? Someone read that line to me one more time. Don't be shy. Go ahead.
Modest increases in life expectancy were possible even in those patients who did not begin regular exercise until age 75.
Huh. You have a decent chance of improving someone's life expectancy even at age 75 starting regular exercise. There is nothing I know on the planet except for the hair club for men that's going to help bring hair back to this head, right? But if I start exercising, I might live longer. My hearing is not what it once was. And I don't know of any exercise that's going to make my tympanic membrane work better so I can hear you better. If I start exercising, I can increase my lifespan. This is cool stuff. All right, so in that article, there was a case report. All right, it talked about this 71-year-old man who was living with controlled hypertension, was active but was developing more knee pain due to osteoarthritis. So he needed increased training, increased activity, and resistance training. So what was the recommendation that was in the article? Read that for me. Tell me what the recommendation was.
Cross-training with non-weight bearing activities of swimming and biking. Wear good supportive footwear, resistant training for legs, and NSAIDs as needed.
Okay, so cross-training with non-weight bearing exercises of swimming and biking. Why was that recommended?
Swimming is usually easier on the joints.
Yeah, why is swimming easier on the joints? There's less pounding, right? I could kick myself in the water, and I weigh a lot less in the water. Woohoo! Let me tell you, right? So yes.
Does that also help increase your bone density? Like if you're still swimming?
Yeah. So it's a great question, right? But wait a second. If you're in the pool, there's less stress on the bone. So would that have an impact on your bone density? Yeah, it doesn't strengthen your bone density as well. It doesn't improve your bone density as well. Good job, good call, right? Because you need that kind of weight-bearing component for the bone density, the load component. Now, the activity of the muscle, right? All muscles are shorten, right? And muscles start at one point, they attach to another point, and they bring the 2 points together, right? That means it's sort of like if I take my hitch of my car and put a chain on there and connect it to the tree stump over here, and I turn my engine on, I'm trying to pull that tree stump, right? Now, what happens if the tree stump is stronger than my connection to my tow hitch? Well, my tow hitch fails, right? There's a stress that's going into the tow hitch, and there's a stress that's going into that tree stump, right? Same thing with muscles when they're attaching to one bone and attaching to another bone. When I do that lifting, there's a stress where that tendon attaches. There's a stress where that muscle attaches. And that stimulates bone formation when I use the muscle. The problem is that you don't get the weight-bearing gravity compression load on the bone as well. You just get the muscle activity load. So it's not as good as weight-bearing exercise. What about biking? So again, non-impact with the ground. It still gets the body weight working and muscles working. Wear good supportive footwear. Well, one of the things that tends to happen with osteoarthritis is the joint tends to break down. This is more common with advanced osteoarthritis. You might see it more so in females, although I don't have a study to back that up. But how many of you guys have seen grandma's knee that looks like it's just way collapsed inside, almost like she bangs her knees together every time she takes a step, right? That arthritic breakdown that collapses. Well, sometimes that happens as a result of not having well-supportive shoes. And so the path of least resistance, which is collapsing inward, happens at the foot and continues all the way through the knee and continues all the way through the hip. So better shoes can help align things a little bit better so there's less of that. Not going to cure it, but it's going to improve it. And then what are NSAIDs, or resistance training for legs? Resistance training for legs, so weights to build strength in the glutes, build strength in the quads. What are NSAIDs? Non-steroidal anti-inflammatories, right? Motrin, Aleve, right? Not steroid-based, but medications that help to control, reduce, minimize swelling. Okay? All right. What about case number 2? Does anyone remember about the 85-year-old woman in the case?
has a previous history of a minor stroke and she has hypertension controlled with a beta blocker. She does not have osteoporosis, or a history of fracture, and is currently sedentary. She has difficulty with eyes closed balance and was unable to stand from a chair without using both armrests, indicating fairly significant leg weakness. She began her exercise program by focusing on balance and strength with a simple home routine based on chair exercises, 12-ounce canned soups, and balancing one leg while holding the kitchen counter.
Okay, so that was the patient who had a minor stroke. She had balance difficulties and some weakness. And so they started her with an exercise that was started as a chair-based exercise. So you can imagine that might be one in which she has a certain level of safety because she's in the chair, not going to fall over. They didn't get really extensive with all kinds of fancy weights, and she didn't have to buy that P90X DVD set, right? She used a soup can to do her exercises. Started with just doing some balance, right? Using the countertop to help her balance. And that was the way they addressed it, right? So, so what were some of the barriers? Well, she needed some strength, balance, right? Some of the barriers were she had a fear of falling. She was older, needed to be able to do it at home. Necessarily didn't need a lot of equipment, right? And so you can see what they recommended, and then we can think of other options, maybe exercise bands, or maybe we have her do some sit to stands. There's different things you might consider that we would do to try to exercise with her. Okay. So, strength training. Why do we need to do strength training? Well, muscle strength declines by about 15% per decade after age 50. 15% loss per decade after age 50. It's kind of a big deal, huh? Where we talked about the largest population of growth was over 85, right? So they lost 15%, and then 15% of that, and then 15% of that, and then 15% of that. Muscle percent per decade after age 70. Wait a second. So they lost 15%, and then 15%, and then 30%, and then 30%. That's a lot of loss, right? Okay. Strength loss is primarily due to sarcopenia. All right, sarcopenia. Well, we talked about osteoporosis and osteopenia, which was reduction in the number of bone cells. Sarcomeres, right? Sarco is a muscle cell. Sarcopenia would be the loss of muscle cells. Okay? All right, so this Framingham disability study, 45% of women older than 65 years and 65% of women older than 75 years cannot lift 10 pounds. 45% of women older than 65 years cannot lift 10 pounds. Let's put this in a real context. I've got 3 amazing rascally kids. Now they're getting big now. I'm the only one that picks them up now. 10, right? She didn't want me picking her up. I still pick her up. Come on, girl. And then I got a 7-year-old and a 6-year-old, right? Now, when these guys popped out into the world, we're talking, these guys were all 9 and 10 pounders. Like, we're talking day 0, right? And then, you start feeding them, and they just keep growing, right? And keep using up diapers, too. Let me tell you, diapers are cheap. $5 a day. Anyway, Grandma, can you hold the baby for me? It's a little scary, isn't it? Well, let me hold the baby. I'll help you. I don't know. Let's see, lift that gallon of milk a few times. Yeah. So resistance training can result in 25 to 100% more strength gains. This isn't mine, but that's literally like mic drop time, right? Strength training can improve somebody by like 100%. Think about that. What helps something by 100%? Like nothing. ADLs and strength. What does ADL stand for? A little louder for everyone.
Activities of daily life.
Activity of daily life. Activities of daily living. What's an activity of daily living? Well, most of you guys seem like you're reasonably well kept, right? So got dressed, maybe tossed a shower in there, move the hair around a little bit, right? Fed, you got to eat, right? Take care of your home. I didn't make the bed this morning, but you make the bed maybe, right? Grocery shopping, right? Load up the fridge, cook, clean. Got to wash a dish at some point or go full disposable. You got to take the trash out, one or the other or both, right? Those are activities of daily living, right? Determinant of walking speed. So walking speed can be a determinant of someone's strength and their ADLs. It can be correlated to their walking endurance. And strength is critical for stair climbing and sit-to-stand transferring. You don't really think about it, but when you stand up, that actually is a physics solution to a problem, right? Take your mass, don't say it out loud. None of you really need to worry about it. I'm here, I do, but everyone else. Take your mass, right? And you're going to elevate that mass by 18 inches maybe. It's a math problem, right? It takes energy to do that. It takes muscle force to do that. What muscle does it? Largely. Your gluteus maximus. That's why it's the maximus. Mac Daddy, it's work, gotta work, right? If that's weak, getting out of a chair is hard. Climbing up and down the stairs is hard. Getting on and off the toilet is hard. Climbing up the stairs to your bedroom becomes very difficult. Getting in and out of your car becomes very difficult. When those things become difficult, can you live by yourself? How many of your grandparents want to move out of their home and live in some sort of nursing home-like situation? Any volunteers who want that, sign me up. I want to do it. Nah, I'm all right. Let me stay in my house, right? If I want to stay in my house, I need to be able to do these things, right? Strengthening of the heart. The rate pressure product is a calculation of the speed of the contraction times the pressure of the systolic. Light housework represents a low stress on the heart, allowing both skeletal and cardiac muscle improvements. Even just doing ADLs can act as a good exercise. All right, keep going here. All right, so exercise precautions. Have a good day at work. All right, most exercises should be able to undergo history and physical. Simple tests for cardiovascular strength have been described. Office-based EKG has limited use. So there's exercise science testing by the American College of Sports Medicine. And so here are the kind of contraindications, indications for exercise according to the ACSM. So absolute recent EKG change, unstable angina, third-degree heart block, acute congestive heart failure, uncontrolled hypertension, uncontrolled metabolic disease, you should not be exercising those people. Relative, well, if they have a history of cardiomyopathy, valve disease, or complex ventricular ectopathy, if they're cleared by their doc, they can exercise. Pretty much everyone else can exercise. All right, so the exercise prescription, 3 components: aerobic, strength training, balance, and flexibility. So initially, sedentary patients to start at a low level and gradually increase their activities. Patients to exercise at a maximal intensity that they're able to comfortably carry on the conversation, the talk test. If I'm exercising, I should be telling you how amazing the Dodgers are and how they're going to just destroy the Cubs and they're headed to the World Series because they're unstoppable, right? I shouldn't be going so fast that I can't talk, right? The talk test. I should be able to hold a conversation. If I'm working so hard that I can't hold a conversation, I'm overworking. Okay. Warm up, cool down, 5 to 10 minutes. Slow walking and stretching should be included. Recommended levels of activity, again from the ACSM, moderate aerobic exercise for a combined total of at least 30 minutes most days of the week. Individually, bouts of exercise can be as brief as 10 minutes. right? So we want people getting 30 minutes of cardiovascular exercise most days of the week. Not 30 total for the week, 30 most days of the week, right? So walking to school and walking home is probably getting you close to that 30-minute mark, if not over, right? 30 minutes cardiovascular work most days of the week. Strength training, single set of 10 to 15 repetitions using 8 to 10 different exercises performed 2 to 3 times a week. So a couple of times a week, at least one set of 10 to 15 repetitions, working a variety of different muscle groups. 3 or 4 for the arms, 3 or 4 for the legs, good deal. All right, we shouldn't avoid holding breath, and training should involve all major muscle groups. Balance and flexibility, stretch major muscle groups at least once per day after exercise when muscles are more compliant. Balance training, weight transfer program twice per week. So maybe during your strength training, do some balance work, right? And after all of your aerobic exercise and whatnot, do a little bit of stretching. U.S. Department of Health and Human Services recommends the following physical activity guidelines for adults. So every day, as much as possible, take the stairs, walk for at least, walk instead of drive, do work around the house, walk the dog, park your car further away. 3 times a week, some cardio, exercise with either sport type stuff or cardio activities. You guys all talk about some of the stuff you guys do. A couple times a week, do some strength training, flexibility training, and cut down on the TV time. All right, so time to do some fitness testing. I've got a few minutes here. So let me pass this out to you guys. Oops, sorry. So all healthcare workers can help overcome some of the barriers. So to achieve the goals of fitness, and we got to improve self-efficacy, change people's attitudes, help them tolerate the discomfort or difficulty, deal with things like there's norms, what they think about, I'm not supposed to exercise, I'm a grandma, I'm supposed to, no, whatever. Okay, their habits, right? Most of us do what we've always done, so try to change their habits. We ultimately do need to worry about some specific issues, if they're fear of injury, or fear of falling, balance deficits, got to deal with those, and deal with environmental factors to try to help move barriers out of the way. So what I've given you here is a senior fitness test, and there's also included on the slide deck is the Tenetti balance assessment. Both things that you can do with folks who are over 60 years old. I believe that's how that scale sets up. Turn the page over for a second. And yes, 60, 64. Now, believe it or not, this test is known as the senior fitness test or the Fullerton senior fitness test. Built here, done by Dr. Reike here at Cal State Fullerton. So kind of a published and famous test, well done, done all over the country by people, validated here at Cal State Fullerton. So go Titans, right? All right, so how does this test work? Well, we got a 30-second sit to stand stare challenge. We can start that. So why don't you guys back up, and we usually like to do it on a fixed chair. So the people on this side of the room, come back to these other chairs behind you here. All right, so so if you guys grab a fixed chair. There's a couple more up here. I don't want anybody falling on their head. Okay, so I'm going to set the timer here. And we're going to have 30 seconds on the clock. Maybe. Next we'll do a stopwatch. Now, no hands, arms are crossed over your chest. How many times you can stand up in the 30-second time frame. So you'll count them yourself. So since you'll be here like this, I'll say go. 1, 2, okay? So 30 seconds, sit to stand. 30 seconds on the clock. You guys ready? And go. Count to yourself. Keep going, about 10 seconds left. 3, 2, 1, time. All right, so write down your score on your sheet. So on the back side, there's sort of a score sheet that you can use. There you go. And then you can write down your score, how many you did for sit to stand in 30 seconds.
Do you have an extra?
Oh, I think I do.
There's some.
Oh.
All right, now we're going to take one volunteer. Oh, I lost my. Oh, he left on me.
Oh.
Oh well. I brought him a weight too. All right, so I need a 5-pound weight, right? And 2 volunteers. Do I have 2 volunteers? Thank you. I don't know if that was actually volunteering. Welcome to my class. All right, so read that number 2 section there for me. What does it say?
So it says up, this one? The description?
Yeah.
Number of bicep curls that can be completed in 30 seconds, holding a hand weight of 5 pounds for women, 8 pounds for men.
Okay, 30 seconds on the clock. We'll see how many curls these 2 can pull off. Okay, ready, go. So they're counting. So you can imagine they're doing this on someone who's a senior, right? And getting a number of where they are. And then if you flip the page over, you can see how they would score based on their age and their gender. So male or female and their age. Then you can see what their number is, and you have a sense of, are they within the normal range for their age? Are they above or below? Okay, time is up. All right, so you guys, how many did you get? 28, not bad. How does that compare to a 60-year-old female?
60?
Yeah, so that first column there. Yeah, she's off the charts. So 16 to 22 would be the typical for that. So these were done on, if you will, healthy or well seniors, right? Independent living seniors. Okay, we have one that everyone can do. So go ahead and everyone stand up, please. We're going to do the last one we'll do together is a 2-minute march test. So basically, you're going to try to get your knee up to about the height of the table, and we're only going to count the right leg. So you left, right, but so it'll be 1, 2, 3, 4, 5. Okay? All right. Now, normally in our clinic, go ahead and start. Ready, go. So normally in our clinic, we have the patient use a walker, just so they have something to balance with. And then we just count the right leg. That's the best RTD t-shirt.
Thank you, Target.
Okay, go ahead and stop. That was only 30 seconds, but we take that test for a full 2 minutes, counting the number of steps. Okay. Now, what you didn't get in I didn't bring as a handout today. Let me back up one step. So we have the sit and reach, which is sort of a flexibility test, and then we have the back scratch test, which is kind of an upper body flexibility test. So we measure the distance between the hands, or if there's an overlap, the negative distance and the overlap between the two. And then we have the 8-foot up and go. So that one, we have a chair. I brought a cone here. We measure out 8 feet. We'd say go. They need to get up, walk around the cone, and sit back down. We measure that time, right? So this is sort of an agility. This is a strength for the lower body. This is sort of a strength for the upper body. This is a cardiovascular capacity. And then these two would be more flexibility capacity, right? So we talked about the balance, the exercise prescription. We have cardiovascular, we have strength, we have balance and flexibility, kind of all in that senior fitness test derived right here at Cal State Fullerton. Right, pretty solid stuff. Now, one of the clinical tests that we'll use is the Tenetti Balance Assessment Tool. I did not print that out for you. It's on this slide deck here, though. And so this is one that we use to kind of measure someone's safety. I quickly threw the scores up here that someone less than 18 has a high risk of fall, 19 to 23 moderate risk, below a 24 has a low risk. So can I get a volunteer? Come on over here to the front. So here's how we do this Tenetti test on somebody. We have them sitting in the chair. Perfect. Come on in. Have a seat right there. Boom. And we say, and you can Google this. I'm certain to take a picture of it, but if you Google Tenetti balance test, you'll find it. It's not a big deal. It's easy to find. So we have a sitting balance. The first thing we say, are they safe in the chair? Are they sitting? Are they leaning? Are they able to sit fine? And if they can, we score them a 1. If they were leaning on one armrest, right, they score them like a 0, right? So, I hate to say it, but, think about maybe someone who maybe had a stroke or someone who's maybe a little bit more lethargic, right? Kind of think maybe if you've ever been in a nursing home, maybe see somebody who's maybe just kind of watching TV, kind of so then we say, hey, go ahead and sit up, and that's still the way they choose to sit. That's how we would score it, right? What's the next thing on the list here? Well, it says rising from the chair, so we say, go ahead and stand up for us. Exactly, well, could she do it, or did she take her a couple of attempts to get up, right? Or was she able to do it? So boom, she's able to do it. We give her 2 points. And so attempts to rise, so she's able to do it without her arms, right? And she didn't need any help. 1, right? So she get 2 points there. She get 2 points here, right? Her immediate standing balance. Well, was she unsteady? Was she staggering, right? If she was, we'd score her a 0. If she needed her walker or she needed a cane, right? How many times have you seen somebody grab their walker so that they stand up and have their walker, right? Then they would only get 1 point. Then we see here, well, what about their standing balance? We say, well, can you stand there and bring your feet close together? So she has a wide base, can bring it to a narrow base. And we say, hey, well, can she handle being nudged? So if I push her like this, does she fall right over or not, right? Being nudged, right? Then I say, hey, close your eyes for a second. So now she has her eyes closed, right? Because she's starting to lose her balance because she's totally visually dependent and not able to use her proprioceptive awareness, right? So then the next thing we might do is that, well, can she turn around and do a 360? Turn around for me.
With eyes closed?
Eyes open, please.
Okay.
Yeah. And go the other direction, right? Does she lose her balance right away, turning around, right? And I say, okay, go ahead and sit back down again, right? And so with that battery of testing, we can score them. Right? They have a gait part, so we'd have her get up, have her walk, just her feet, her steps, does she clear, or does she drag her toe catch as she's walking? Is her foot clear? Is there symmetry in her steps? Does she deviate off of the path? So we can look at all these different assessments and give her a total score. And if her total score was less than that 18, we say, ooh, she's at a risk of falling. Maybe she needs a walker, she needs a cane, she needs something to help prevent those falls. Nursing home need to keep close eye on her when this person's up and walking by themselves. So these are just a couple of clinical tests that we can use to try to assess some of these elderly people. All right, so are there any questions? Yes.
Do you work at your own? Like, do you have a clinic?
I sure do. I had patients all morning, and I had patients this afternoon.
So do you use these?
I do.
Okay.
Yeah, so we'll use those, and partially, in this case, because of Medicare, we'll use a test to show people's deficits or difficulties they're having, and then be able to demonstrate progress and say, hey, this person's now within the normal range or not in the normal range. So that's not the only test we use, but we do use different tests like that. So yeah, these are very clinically relevant tests. So the goal today is for you guys to see how we could take something from the literature that talks about what we could do to try to help people function at a higher level. We could start to explore some of the elements of that, right? So we talked about the whole gamut of things, right? From osteoporosis to cardiovascular health to exercise physiology, right? We integrated these different sciences, right? And then try to apply it in a clinical setting. That's kind of the goal of graduate school, taking this base science knowledge that you guys have and maybe trying to apply it in different ways. So those of you in the public health arena can say, wow, you know what, exercise can make a big difference to our elderly and our quote, old population. Maybe we've got to think about different ways that we can get that message out, different ways we can reduce the barriers to activity and exercise, ways that we can encourage group home situations where they can maybe facilitate more exercise activity, senior centers. Maybe there's a reason why it's worth publicly supporting senior centers so that seniors have a place to go where it's safe and the equipment's built for them and they're not fighting the 20-year-olds to get to the weight machines, right? So So maybe there's some thoughts about that from a public health point of view. You clinicians or future clinicians in the room, maybe think, wow, maybe there's something else I need to assess in this population that I can maybe implement that can make a profound difference in someone's overall life, not just their immediate complaint or why they walked in the door today. So hopefully this was enlightening, if not fun, or at least you had a chance to look at some of this stuff. This is what we do in PT school. We take articles like this. I told you about the article reader, and we try to take those and apply them